we'll just the first little bit is just kind of introduction. I can give you an update. The Mariners are down 4-3 on the top of the fourth right now. So we'll be keeping an eye on that. So basically tonight we'll talk about stem cell treatment. It's just kind of a general overview of stem cells and the different things that we treat. Um, so just a little bit on me. I've been practicing here in Seattle for over 35 years. I was the founder and president of Seattle Sports and Regenerative Medicine. That was about 8 years ago here in South Lake Union. Prior to that, I was senior partner and medical director of the Sports Medicine Clinic, which was the oldest and largest sports medicine clinic in the country. I was on staff for quite some time at the University of Washington, consulting team physician for the Seattle Mariners. I'm a fellow of the American Academy of Family Practice, as well as a diplomat of the American Board of Family Practice. I'd like to thank IRG Hand and Physical Therapy for inviting me to speak and for helping to sponsor this webinar. They're a fabulous group of physical therapists who I use all the time and do a great job. So what we're going to talk about, I'll kind of go through just a very quick overview, and then we're going to get into each of these and actually probably a few more. So what we'll do is we'll start bottom right-hand corner, tendon injuries. Some of the more common tendon injuries that we treat are Achilles tendons, partial tears, patellar tendons, quadriceps tendons, which are basically below and above the knee, respectively, and rotator cuff. We also treat tendon injuries to elbows, like tennis elbow, golfer's elbow. Next, coming up on the circle here, chondromalacia. Chondromalacia is damage to cartilage, most commonly in the knee, like behind the kneecap. It's damage to that articular cartilage, the Teflon covering of the joint. Then moving up, rotator cuff tears we treat, partial anterior cruciate ligament tears, and actually some complete, which I'm going to talk about a little more. It's not something that is that I'm not a big fan of, but I've done a few and they've done great. Labrum tears. Okay, what's a labrum? Labrum is analogous to a meniscus. So when people talk about meniscus tears in their knees, the meniscus of the shoulder and the meniscus of the hip is called the labrum. The structure is a little bit different. They're more like a gasket or a rim of cartilage. Moving on to the left, meniscus tears, used to be we had to take them out. Now we can treat them and heal them. The big thing we treat, osteoarthritis, ankles, knees, hips, wrists, elbows, shoulders, big toes, thumbs, sacroiliac joints, and we'll talk about all that a little bit more. Osteochondral defects. A lot of times in younger athletes, we treat these. They're basically, it's like a punched out lesion. If you were to just punch out a piece of cartilage and bone within the knee joint or the ankle joint, that's where we see them most commonly. And then synovitis, which is just basically inflammation of the lining of a joint. So the lining of a joint is the synovium, and it's kind of like a feathery type tissue. Okay, moving on. Osteoarthritis, this is what we treat more than anything else. This is actually a patient I did 10 years ago. This is bad arthritis. This is severe arthritis. Still a little bit of joint space there, but not a heck of a lot. This was a patient who came to me after seeing the surgeon and said, absolutely do not want to do surgery. I'm not going to do it. And I can't remember, she may have even been referred from her surgeon. This x-ray was done 10 years ago. She came back in to see me for something else, maybe 3 or 4 months ago. And I said, well, how are your knees doing? She said, oh my God, it's been incredible. I mean, granted, she's not running marathons, but she's doing all the activities and things that she enjoys doing. So osteoarthritis is breakdown of that Teflon covering of the joint. Typically, patients with mild to moderately severe osteoarthritis do very well. Now, granted, I never used to do patients with severe arthritis when I first started this 10 years ago. However, I ended up getting a lot of referrals from other patients, from physicians, from orthopedic surgeons who said, you're not a candidate for total knee replacement. You got heart issues, you got COPD, you're not going to do well in general anesthesia, or you're obese, and we're not going to do the surgery because the complication rate is so high. Um, and so they send them to me to do stem cells. And these people actually do very well. We see a lot of arthritis in lots of other joints. This is just, I actually spoke to the foot and ankle surgeon's annual meeting on Sunday. So I've got some joints here, or some x-rays, basically where there's arthritis in the midfoot. You can see these bone spurs, and this joint right here in the middle looks, very kind of white and sclerotic, and that's osteoarthritis there. Osteochondral defects. So these are areas that we talked about earlier. It's like a punched out area. Most commonly, we see them in the knee and in the ankle. They can come about as a result of trauma, or sometimes for whatever reason, the blood supply to that particular area of the bone and cartilage just stops, and the overlying bone and cartilage dies, and you get these areas. These respond incredibly well to biologics, which is stem cells. The other option, which I don't see great results with, is something called microfracture surgery. I end up seeing a lot of those patients who say, well, I had microfracture twice and then I had to clean out and it's still not good. And we treat them with stem cells, and for the most part, they do exceptionally well. Meniscus tears. Okay, so we used to, it used to be, all right, you got a meniscus tear. Well, there's no blood supply to the meniscus, so they're never going to heal on their own unless the tears are way out to the outside, like in the outer 10%, which is a very small percentage of the tears. So all you can do surgically is go in and cut them out. Well, that's not a great thing to do. There's a reason that you have meniscus in a knee, and it's to provide support and to provide cushioning for the knee joint. You take it out, you're going to end up with arthritis eventually in the knee. And if you try to suture them, I mean, you could put sutures in them all day long. They're never going to heal because there's no blood supply. So what do stem cells do? They put a blood supply there so that those menisci can heal. And I've had a number of patients that we've treated, and for one reason or another, they see me 5, 6, 7, 8 years later, they injure something else, or they have a separate injury. We end up getting another MRI. And I actually had a radiologist call me a few weeks ago to say, hey, Mark, I got to tell you, this patient you just sent in has absolutely no evidence of meniscus tear. I looked at her old MRI from a number of years ago. There was a big tear in her meniscus. I had to go back, check her name, check the date of birth, and look at it again because I was so surprised by the fact that it was completely healed. So, I mean, we do see that a lot. Labrum tears are kind of like meniscus tears. They don't have blood supply. We see them most commonly in the hip and in the shoulder. Well, not most commonly, that's where you see labrums. And those tears can cause pain. They can cause sharp stabbing pain. They can cause catching in the joint. We see them a lot of times in young, healthy people, as well as people who have osteoarthritis. Partial ACL tears. So if the anterior cruciate ligament is still intact, but there's a partial tear, 30%, 50%, high-grade tears are considered greater than 50%. I've done a number of high-grade tears. I always give the patient the option, and oftentimes refer them to one of the surgeons just to get a surgical opinion. The issue with partial tears is, in order to fix them, you have to destroy the ligament that's already there. So, and that's not a great thing. It's a big surgery, an ACL surgery. Partial tears do really well with stem cells because the stem cells that we isolate from bone marrow and fat can grow up to be muscle, tendon, cartilage, and bone. And they only go to where they need to go. I do have actually 4 cases of complete ACL tears that I have treated. One is a Norwegian silver medalist, Olympic cross-country skier, Nordic skier, who had an ACL done, had a complete tear in her ACL, had it done actually in Norway. She brought me the MRI from prior to the injury and then a year after the injury. And it was the same sort of thing. I had to make sure the dates were right, the names were the same. She had complete healing of her ACL, and on exam, had a completely stable knee. The reason she was seeing me, she was bringing her mother from Norway to see me for osteoarthritis in her knee. Subsequently, I had a patient who was an MMA fighter who had a complete ACL tear. And so I said, well, I'm going to send you over to one of my buddies at UW, a surgeon, to repair the ACL. She said, no. She said, I do not want surgery. I've done a lot of research on this. I want to be back competing and fighting quickly, and absolutely don't want surgery. She said, I want to do stem cells. I said, well, I got to tell you, it's not something that I typically do because there's not great data out there to say that you can get healing of complete ACL tears. Anyhow, she understood that. We did it. I lost her to follow up until about a year ago. So this has been about 3 or 4 years where she came in and she had torn the ACL in her other knee and wanted it done. I said, well, wait a minute. How's your knee that we did 4 years ago? She goes, oh my God, I've been competing since 4 weeks, no, 4 months after the procedure. And I'm 100%. And her knee was completely stable, no instability like she'd had before. Anyhow, we did her other knee. Once again, I recommended it surgery, but she didn't want it. And then she has subsequently sent one of her friends who is also an MMA fighter for the same thing. And that patient is about 6 months out now doing incredibly well with no instability whatsoever. This actually was the ACL. This is an MRI. And basically, kind of the area in the middle that's this kind of gray, light gray, white that angles. That's the anterior cruciate ligament. It should be a black, solid line. And this just shows it was a fairly complete tear. I think there maybe were a few little fibers still hanging on here. And I think what happens if there are some fibers there, it's kind of like a blueprint for those stem cells to go in and to regenerate tissue. Rotator cuff tears. If somebody has a fall, they land on an outstretched hand and they boom, they hear a pop, and all of a sudden they can't lift their arm up. That's a complete rotator cuff tear. And usually we document that with an MRI. Those I send right off to the surgeon because the stem cells are not going to bridge that gap. However, if somebody has a partial rotator cuff tear, they do better with biologics than they do with surgery. The reason being, the area where the rotator cuff tears is called the avascular zone. It's got a really poor blood supply. And if you go in and you put sutures in it, it compromises the blood supply even more, and 60 to 90% of those surgeries fail within 5 years. So what stem cells do is they can augment and repair the tissue as long as it's still somewhat intact. Now, sometimes we see full thickness tears, but not full width tears. So it takes looking at the MRI to see, and also examining the patient to see what their function is like. Um, Move on. Chondromalacia, usually behind the kneecap and where the kneecap meets. It's damage to that Teflon covering of the joint, but it hasn't gone deep enough where it's really starting to affect the bone. We see this in a lot of runners. And they come in to see me because they've done physical therapy for 6 months. They've gotten orthotics. They've done gait evaluations. They've had cortisone shots. They've had MRIs, and nothing's helping. I can tell you a story about a kid who I did who was a swimmer at USC, a big kid who was lifting too much weights in the weight room, um, and damaged the cartilage behind his kneecap because the swimmers and the football team practices together or lifts together, and there's a lot of testosterone flying around in the weight rooms there. Well, he had had everything done for a year. He had PRP injections, cortisone injections, physical therapy, taping, everything, and just was not getting better. And he ended up calling me up and saying, "Dad, can we please do stem cells on my knees?" And at first I was like very hesitant to do it. And I said, "Let me refer you to somebody and to do it because you don't want to do a procedure on your own child." But he said no, that he was only going to do it if I did it. And so we did him. He has subsequently done Ironman races, marathons. He's got zero pain in his knees after about 4 to 6 weeks of the treatment. Tendon injuries, Achilles tendons, and the other tendons around the ankle, posterior tib tendon, peroneus brevis, peroneus longus. If they're partial tears, they do extremely well with stem cells. If they're complete tears, it's a different story. Then we talk about surgery. This is a partial tear of an Achilles. There's still some fibers here, the dark portion. This is a guy who we did about, I bet, 7 years ago. He's a golfer and tennis player. He's doing fine, has no issues whatsoever. This same gentleman has had 8 different joints treated with stem cells. He said knee arthritis, rotator cuff tears, tendon injuries, hip arthritis, and he's like a billboard for stem cells. Synovitis, inflammation in the knee joint. These, for the most part, I say for the most part, well, a vast majority of them, women runners, knee pain, they've done everything. And they come to me because they want to do stem cells. And I look at their MRI, they have normal MRI, normal x-rays. I say, you know what, let's just do PRP. And I bet you're going to do fine. And 99% of them do fine with just PRP. So we're going to talk about what is PRP. PRP is platelet-rich plasma. We draw blood, we isolate the platelets. Platelets are these great little packages of growth factors and cytokines and exosomes and ultimately decrease inflammation. We do a lot of PRP injections for tennis elbow, golfer's elbow, synovitis. And then when we do the stem cell procedures, we usually do stem cells from bone marrow, stem cells from fat, and PRP. Okay, so what's regenerative medicine? The field of study that utilizes stem cells to heal and regenerate damaged tissue. This is the important thing, the word autologous. The use of autologous, meaning from your own body, adult mesenchymal stem cells to regenerate bone, cartilage, muscle, and tendon. Stem cell, it's basically an undifferentiated or an unspecialized cell in the body that has the ability to renew themselves and transform into different cell types. The only stem cells that I want are called adult mesenchymal stem cells. And by virtue of a very complex software program that runs our centrifuge, we're able to isolate those cells in billions. And that is the important thing. It's the numbers of cells that you get. Okay. So I have a quick look, like a 4-minute like cartoon, but I kind of really like it. It just explains about the procedure and stem cells. So I'm going to start this now.
What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and reduce pain. It is used for arthritis and injuries to ligaments, tendons, muscles, cartilage, and bone. First, let's look at the difference between human embryonic stem cells and adult stem cells. The embryonic stem cells are pluripotent, meaning that they can become any of the more than 200 known differentiated cell types of the human body. On the other hand, adult stem cells are multipotent, meaning that they can develop into more than one cell type, but are more limited and controlled, and thus safer than pluripotent cells. We perform the adult stem cell treatment. What is the role of these stem cells? To understand this better, let's look at this example. Your house is exposed to different elements, such as wind, fire, rain, sun, and time. All cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and a contractor to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. Stem cells work with a contract that, in addition to giving instruction for repairs and maintenance, can transform the specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there's a balance between damage and repair, and you have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than the ability of your body to repair it. This leads to an imbalance and ultimately leads to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job, or sometimes the amount of damage is too much for the available stem cells. But fortunately, there are areas of your body that keep a good number of stem cells. These areas include the bone marrow in the hips and the fat in your abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that did not improve with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Okay. All right. So when we were 10, I'll give you an update. The Mariners are still down 3-2 on the bottom of the sixth. When we were 10, we had 200 million stem cells circulating around in our bloodstream. When you hit 60, that drops down to about 2 million. So, but there are still areas in our body, mainly our bones, where we have, and fat, where we have lots of stem cells. And that's where we get them from. We get them from the back of the pelvis. Kind of the love handles area is where we do the adipose, get the adipose or the do mini liposuction. And that's where we get the bone marrow aspiration as well. Stem cells they regenerate tissue, but they also have anti-inflammatory properties, as does the platelets. So a lot of my patients come to see me because they don't want a total knee replacement. Total knee replacement is a big surgery. It's a year of rehab. It's a significant amount of downtime where oftentimes if patients don't have help at home, they have to go into a skilled nursing facility. If they have help at home, it's a different story. Big data, 65 to 70% of patients who have knee replacements are happy, but 30 to 35% are not happy and they wish they'd never had it done. There are, first of all, it's a year. Sometimes the pain can be worse afterwards and then you're stuck. It is an end game. There's always a risk of things like infection, DVT, which are blood clots, which can break off and go to your lungs, causing pulmonary emboli. There's a risk for heart attack and stroke. Loosening, the knee joint's it's not going to last forever, 8 to 15 years. It all depends on your weight and how active you are. There are studies out there that suggest that there may be an increased incidence of dementia with total joint replacement, and that is because of metallosis, which is chromium, cobalt, nickel, and titanium that leach into your bloodstream and end up in your brain. And know that all of these complications are increased when your BMI is over 28. There are actually some studies out there that show that men and women over the age of 60, for the 1 year following a total knee replacement have a very significantly increased risk of heart attack and stroke. Like I said, I was talking to foot and ankle surgeons, their annual meeting over the weekend. So patients who have bad arthritis in their ankle joints basically have two surgical options. One is a total joint replacement, and the other is fusion. Both are big surgeries. One basically leaves you with a very stiff joint. There are a lot of factors that need to be met in order for patients to be candidates for joint replacement for the ankle. You can't have any type of peripheral vascular disease or diabetes or osteoporosis or damage to the square bone in the middle of the ankle, which is talar osteonecrosis. Or if you don't have a lot of good soft tissue around the joint. The other thing that could happen, nerve injury, a fracture that's caused by the surgery, failure of the components. There's not a lot of great blood supply to the lower extremity in older patients. So wound healing can be an issue. Patients can end up getting ulcers, infections, tendon injuries, and then significant scar tissue. So what do we do before the procedure? We tell patients no anti-inflammatories starting a few days before and then for 6 weeks afterwards. The reason being, the way stem cells work, along with platelets, is the way we heal is by inflammation. You gotta have inflammation in order to heal. So we don't want an anti-inflammatory stopping that process. So no non-steroidal anti-inflammatories. That means no Advil, ibuprofen, Aleve, Motrin, CBD, turmeric, and those type things. We tell patients drink a lot of water 48 hours beforehand because we want to be able to draw the blood to get the platelets. The only medications that are an issue is if somebody is on a blood thinner, sometimes we'll stop it for a day or two before the procedure. And then if it's something that they can't stop, we talk to their cardiologist or internist and see we can get around that. There's ways we can get around that with things like Lovenox bridges. So what we do, first we draw blood. The blood sample goes into this computerized centrifuge and we isolate platelets, and we're getting trillions of platelets. We then do the bone marrow extraction. That's the thing, people always come in and they have this notion that it's like the worst pain in the world. I've done over 20,000 of them. It takes me less than a minute to do a bone marrow aspiration. And I would say half the patients are like, you kidding? You're done already? And half of them are like, oh my God, wow, that feels like sciatic nerve pain, or feels like a pain I can't describe, like a deep hollow sensation or a deep hollow ache. But if you're in that 50%, it's going to last about 30 seconds. As soon as that trocar, the needle is out, the pain is gone. We then, kind of in the love handles area, do a mini liposuction, which you really don't even feel at all. Because remember, we're getting stem cells from bone marrow and from fat. We isolate just those adult mesenchymal stem cells, and then along with the platelets, we utilize ultrasound to guide our injections into whatever joint or tendon or muscle that we're headed, for. The whole procedure takes about an hour. And everything's done at the same time: the extraction, the harvesting, the concentrating, and the injections. It's local anesthetic. We give you some pain meds ahead of time. We listen to music. Patients walk out. They do need a ride, but they walk out and they start physical therapy a week later. And we just find a good physical therapist close to home. Most people start to see, I'll come back to that. Most people start to see improvement in the 6 to 12 week range. Although I have some people who say, God, 2 weeks, I was great. I have some people say, well, it took 4 months, 5 months before I really started to see significant improvement. So it can vary tremendously. Who don't we do the procedure on? I talked about blood thinners. We still do it, but sometimes we have to stop them or modify things, and we kind of look into that. If somebody is undergoing chemotherapy or has metastatic type cancer, I always talk with their oncologist to see, are there any contraindications to doing bone marrow aspiration? If there are, we just do adipose, in other words, fat. So we do stem cells from fat and PRP. And if somebody has an active infection, we're going to put the procedure off. Oops. So one of the things I really caution patients about, a lot of people come in and say, well, doc, I'm 75, I'm 80, I'm 90. And we've done over 500 patients in their mid 90s and 2 women over 103, or who were 103. One lady came in, she had both her hips done. She was so thrilled, she brought her 103-year-old friend in to have her hips done. So patients come in and they say, oh, you know what? I know my stem cells can't be any good anymore, and I heard that. I heard someone saying, or I went to see the chiropractor somewhere or another physician or a naturopath who said, oh, you don't want to use your own stem cells. We want to get young, embryonic stem cells. Well, that's not a great thing. Anybody can buy stem cells online. You can go home, you can do it right now. The problem is they come from women who are willing to sell their placentas. It is somewhat of a sketchy patient population. Most of it comes from south of the border. There are no live stem cells in that product. It's a desiccated powder that a lot of chiropractors do. They hire nurse practitioners because they're not allowed to do the procedure. And they basically reconstitute it with sterile saline and inject it into joints. I have seen some real disasters come from a lot of these providers. Infections. One gentleman unfortunately ended up having an above the knee amputation after seeing a local chiropractic group. After 3 months of trying to clean his knee out, putting him on IV antibiotics, it just didn't work. I've seen people come who went down to Panama and Mexico and the Cayman Islands who came back with overwhelming knee pain that was worse than it was before they went down. So I would just really be careful about using any cells other than your own, and also making sure that you see somebody who's done a ton of these and is board certified and has a lot of experience in them. So our results, basically, big data before I get to our results on the left-hand side, 85% of patients obtain at least 80% improvement. In our hands, basically, which a large number, 91% of our patients obtain at least 75% improvement. It's a very safe procedure. I'm going to go over I'm going to highlight some conclusions from scientific journals and clinical studies. This one is from Advanced Biomedical Research. Once again, this was for the foot and ankle surgeons. It talks about the efficacy of managing osteoarthritis with PRP and stem cells. Basically, this one talks about significant improvement in pain and function when treating plantar fasciitis. This was a lesion. The X-ray, you can see there's like a chunk taken out of the ankle. That's an osteochondral defect, like we talked about earlier. And this study, out of the Bone and Joint Journal, just shows that after removing a loose piece that was floating around in the joint and then treating it with they just used adipose, in other words, fat stem cells. And repeat MRI done a year later showed successful regeneration of cartilage. Once again, you can see right here, there's a blow up of that hole that's sitting within the bone and the cartilage. That's an osteochondral defect. Once again, this was a study that also on osteochondral defects on ankles shows that you definitely see regeneration of cartilage over a 24-month period of time. From the Journal of Bone and Joint Surgery, there was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. From Journal of Clinical Orthopedics and Trauma, basically they say versatility of stem cells as a treatment modality has landed it another repair target, osteoarthritis. This newly discovered method has been shown to significantly alleviate pain experienced by osteoarthritic patients. From Helion, a single intra-articular injection of bone marrow stem cells provides long-term benefit. The procedure is simple, fast, well tolerated, avoids the need for hospitalization and general anesthesia, and there were no complications or adverse effects. Um, Basically, they're talk here that stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs such as osteoarthritic joints. From Nature, which is basically the British Journal of, or New England Journal of Medicine, in conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any adverse or any severe adverse effects. Then they did, this is another one, they did cartilage mapping by MRI, shows evidence of improvement in good cartilage quality and significant decrease in poor cartilage quality. So I won't go, I have a number of studies that I put in here for the surgeons, but we don't need to go, through all of these. They basically show, because the thing that a lot of patients come and they say, well, I've been told, or the surgeon said, I'm bone on bone, you can't regenerate cartilage with stem cells. But all these studies show, and anecdotally, we end up doing MRIs for whatever reason. Somebody comes back a few years later and has another injury. We end up doing an MRI. We say, look at this, we see, regeneration of cartilage in the meniscus and the articular cartilage. So, we definitely do see that. Very safe, no general anesthesia. Anytime you put a needle in a joint for whatever reason, whether you taking fluid off, putting cortisone in, whatever, there is always a risk of infection. Although, knock on wood, I've injected literally hundreds of thousands of joints in my career and have never experienced an infection. Afterwards, patients walk out, they're a little sore, a little achy. I say RICE, but it should be RCE. Rest, compression, elevation, no ice. Remember, we don't want to stop inflammation in that first 6 weeks. We want inflammation. Most people don't feel it. They're a little achy. Most people get by with Tylenol. We give them pain meds if they need it for sleep the first night or so. We start physical therapy 5 to 7 days after the procedure. Usually most people, they're back on a stationary bike in 2 to 3 weeks and then onto an elliptical, and then they just progress back to activity. Okay, that's kind of my overview. Now we're going to open it up because I know a lot of people have questions about specific joints, specific things that they want to ask. So I will sit here as long as we need and kind of go over those. Chelsea's going to help me out here. All right.
Okay, so first question was, I think we already answered this, but where do the stem cells come from? How do you get them?
They come from bone marrow. We do bone marrow aspiration and from fat. So we get them from 2 different places. The stem cells from bone marrow are robust and long-lived. The stem cells from fat are prolific. We get tons of them.
Okay. The next one is, there's someone asking, they're 75 years old and active. They've had meniscus tears 20 years ago and suffer from inflammation in their feet and toes. Is it something that's reasonable for them to undergo?
Certainly, it would be worth looking at and seeing, at least, a consult to see. Typically, if you had meniscus tears 20 years ago, and if they were treated surgically or if they were left alone, they probably have started to cause some problems with osteoarthritis in the knee joints. And as far as the feet goes, it all depends. I mean, not everybody's a candidate, but certainly, worth setting up at least a consult to take a look at the feet and get some images and as well as the knees and see what's going on.
Someone else asked if this works on sacroiliac joints.
It definitely does. We do a lot of sacroiliac joints. It's fairly quick and simple. If there's significant, arthritic change in the joint, we do stem cells from bone marrow and PRP. We don't do fat in sacroiliac joints. Sometimes if it's just a little bit of inflammation, and we'll just do PRP, but it all depends, to take a look at with a consult.
There's a couple of people asking about cost and insurance.
So unfortunately, insurance does not cover stem cells for orthopedic conditions. It does cover stem cells for leukemia, lymphoma, burns, and wound healing. And if they're used intraoperatively, so another, and nobody's up here is really doing that, but I have some friends in Florida and California and Texas who will repair like an anterior cruciate ligament or a rotator cuff surgically, and during the course of the surgery will lay down stem cells with a biological dressing. Then it's covered by insurance, but not covered by insurance for non-operative procedures. Now, people can and do use, like if they have an HSA or an FSA, health savings account or flexible spending account, you can use those type funds for it. Now, physical therapy is covered, consults are covered by insurance. It's just the procedure itself that's not. And the procedure runs, anywhere from, well, depending if it's a small joint or a large joint, anywhere from like $3,500 to $8,000 for single joints. Now, a lot of people come in and say, "Oh, I got both knees are killing me," or "My knees and this hip or this shoulder." It actually, the big cost of the procedure are the surgical kits. So if we do more than one joint at a time, it does save patients a lot of money. So for instance, you do a single joint, might be 8,000. If you do two joints, it might be 11. So I mean, it does save you a lot of money if you combine the joints.
Someone asked how often it can be done in the same area.
So it can be repeated. Um, for instance, I had a guy come in 4 or 5 weeks ago who I'd done 10 years ago. I'd done both his knees. He's a big guy, very loud, and I knew who he was. I could hear him talking in the waiting room. Just a very funny guy. And I came into the exam room and he looked at me, he goes, "Doc," he goes, "Do you remember what I said to you 10 years ago?" He goes, "My wife dragged me in here." And I looked at you, I said, "Doc," I said, "This is voodoo. This is bullshit. There's no way this can work." He said, "I got to tell you, man, I've referred over 20 patients to you, including my son, who have all had the procedure done." He goes, "It's been incredible for 10 years. Now they're starting to bother me a little bit. I still don't want total knee replacement. Can we do it again?" Yeah, it can be repeated. So,
A couple of people asking about downsides or negative effects. One person said that they had someone who developed gout post procedure, and
so we do see that. I bet we've seen that maybe half a dozen times out of 20,000 or more. For some reason, any type of surgery, trauma, dehydration, stress can cause a flare up of gout. We treat it with some colchicine and usually it gets better quick. That's another reason why we want patients to stay well hydrated, so they don't get a gout flare. But it's been a very, very, very small percentage of patients.
Someone asked about how long not to play like sports after.
So we usually get people back. So if we're talking, lower extremities like ankles, knees, and hips, usually at 2 to 3 weeks, you're spinning on a stationary bike, you're onto an elliptical. I'll get people back on average, and this isn't everybody, but we can usually get people back to easy skiing, hiking, golf around 6 weeks. And then by 12 weeks, back to whatever feels okay. Things are pretty rock solid by then. As far as like shoulders, elbows, wrists, those you're doing everyday activities right from the get-go. Yeah, I don't want you, hanging off. I don't want you doing American Ninja Warrior for 3 months or so. But people are, at 6 weeks are starting to do overhead, push-ups, military, bench press, things like that, and getting back to activity. And it varies depending upon the patient and what the issue is too.
Someone asked about the difference between PRP and stem cell, and specifically a series of PRP injections or monthly PRP injections.
So there are a lot of people out there who use different systems for PRP where they're only getting maybe, I don't know, hundreds of thousands or maybe millions of platelets. The system that I use was actually developed by a buddy of mine who ran the molecular biology department at UCSD, and I believe he was at Stanford as well. And he was just brilliant. The software program gets us billions to trillions of platelets. So typically, we only have to do one-time PRP injections. Rarely I'll repeat it. Could be 6 months, a year, 2, 3, 5 years or so. People come in. You shouldn't need to have monthly PRP. If you're having monthly PRP injections, you should have stem cells, most likely, because there's something else going on there. PRP decreases inflammation. It doesn't regenerate tissue.
Someone in that vein asked if there's a reason to try PRP first before considering stem cell if they have osteoarthritis.
Well, like I said, at best, it may give you 6 months of relief. So I've had a few people who have come in like every 6 months and done PRP. And then after a couple of years, they say, geez, why didn't I just get the stem cells done 3 years ago? It would have cost me the same thing, basically. And so PRP, it can buy. I do have some people though who come in and say, yeah, I know I got arthritis in the knee, I got a meniscus tear, but I got this big golf trip to Scotland coming up, or I got this trip, and the stem cells is going to lay you up for 6 weeks. Not that you wouldn't be able to do it, but we want to protect those cells. Those cells are expensive, and they're a little bit fragile. Whereas with PRP, after 48 hours, you can kind of get back to activity. So I'll have some people say, hey, you know what? Let's do PRP now. And then when I'm done with my trip in like 3 months and I got everything out of the way, then I'm coming back and doing stem cells.
Someone asked if they would be a candidate if they've been diagnosed with osteonecrosis.
It all depends. That's probably talking about a hip. If there's not severe collapse, I mean, I have patients who come and say, I don't want a total hip replacement. I want to buy some time, or I'm overweight. I got to lose 50 pounds before they'll do the hip replacement. And a lot of those patients, yeah, will do stem cells for it, and they do pretty darn well. But a lot of times I'll say, you know what? You got bad arthritis in this hip, you have osteonecrosis, or maybe even you have a little bit of collapse. You know, are you going to eventually need a hip replacement? Yes, maybe. So are we trying to buy you time because you're young or you're overweight, or there's some other issues? Yes, we're trying to buy you time. Maybe we can buy you 5 years. Maybe we can buy you more than that. But for some people, it may be, hey, this is not a do all end all. This is not going to be for the next 40 years. It all depends. It all depends what things look like.
Someone asked, does our office do an MRI before procedures for osteoarthritis?
Sometimes. Now, if you've got an X-ray that shows osteoarthritis, um, oftentimes it's like, I'll give the patients the option. It's not going to change our decision-making process. So that's the way I look at diagnostic studies. It's not worth spending, $2,000 on an MRI if it's not going to change our decision-making process. If we look at a knee and say, oh my, you got osteoarthritis here, your options are total knee replacement or stem cells, or leave it be. Well, if we did an MRI, it's going to come back and it's going to say osteoarthritis. Maybe there's a meniscus tear, but that wouldn't change our decision making, because even if there's a meniscus tear, you're not going to do surgery on a meniscus tear if somebody has osteoarthritis, because we know that if you put a scope in an arthritic knee and try to fix a meniscus tear, there's a 15% chance you'll be better at 1 year. There's a greater than 50% chance you'll be worse.
Someone asked, after the treatment, can someone walk 2 miles? And is it successful if someone weighs about 200 pounds, or should they lose weight and then try to go for the procedure?
No, I mean, 200 pounds is nothing. We have some people we actually have done. We did a woman from Centralia. I want to say she was like 450, 500.
Yeah.
And she was in a motorized scooter. She hadn't been able to walk for 6 years. And I can't remember, I think we did her hips and her knees. I can't even remember.
Okay.
She had no surgeon would touch her. And she came back to see me at 6 weeks and then at 3 months in tears, walking with, I think maybe she had a walker or a cane. She said, Doc, I have my life back. I haven't been able to walk for 6 years. And so we don't want people to go on crash diets before the procedure, because those cells need nutrition. So we don't want you, trying to crash and lose weight. You'll lose it eventually. If your knees feel better, your hips feel better, your ankles feel better, then you're able to exercise, you're able to lose weight.
Someone was asking for an energetic 97-year-old. He needs a knee joint replacement again, but has a cracked femur on the same limb. His physician is afraid to operate. What's your opinion?
Oof, that's a tough one. Certainly stem cells are not going to be an option because all you got is metal and plastic in that joint if he's had a total knee there. What I do sometimes for patients who have painful total knee joints is I'll just inject some platelets, some PRP, and see if we can decrease the inflammation. Because when there's a prosthesis in there, I mean, the stem cells are just a waste of time and money. But PRP might be an option.
Someone asked, have you treated arthritis in the foot, specifically high arches? They've been told surgery is the only option.
We don't necessarily treat like quote unquote high arches, but we do treat if there's arthritis in the midfoot or in the bunion. You know, when people talk about bunions, that's the first MTP joint. But the joint specifically, talonavicular joint, cuneiform joint, the cubonavicular joint, the metatarsal tarsal joints. So we treat all those. It just depends kind of what things look like, where the pain is, and what the images look like. But it's not going to do anything for the arch itself.
Someone said that they're 48. They want to delay / avoid a total knee replacement. They're active, skiing, backpacking. They have grade 4 osteoarthritis on the outside portion of their joint. Can stem cells still help significantly when it's bone on bone, grade 4 osteoarthritis?
First of all, you're way too young for a total knee replacement at that age because it's only going to last you maybe 8 to 12 years. And then you got to have it done again, and then again, and then again. You know, God willing, you're around on this earth for a long time, and you don't want to have it take 6 to 12 months off every 10 years for a knee replacement. And the fact of the matter is, subsequent knee surgery, knee replacements never do as well as the first one, if the first one even did well. So and the other thing I bring up is I bet 95% of patients who come to see me and say, oh, I've got grade 4 osteoarthritis on bone aren't. And I'll look at their films, the same films that somebody told them they were bone on bone, and we'll sit down and we'll look at them and I'll say, well, you show me, where is it bone on bone? I mean, you got joint space. So I don't know. A lot of people are under that impression that they're bone on bone. I did find out from some friends of mine at Regents who I talk to all the time. The reason bone on bone is thrown around so much, in order for insurance companies to cover total knee replacements, that has to be in the dictation. One of the things that I do a lot, I use Hanger Clinic, which is a prosthetics clinic. They're all over the country, and they're in every major city. They just came out with, I bet 6 months ago, this new brace that they came and they brought to show to me because we use them a lot. That is a laser guided 3D printed brace. They're feather light. They fit perfectly like a glove, and they can unload specific compartments in the knee. I just have to specify how the brace is built. And so we'll do stem cell procedures and then put people in these braces for skiing, backpacking, hiking, tennis, whatever. And they unload that arthritic joint. So I'd say definitely worth a consult and looking into both the biologics and the bracing.
Someone else asked if 0.5 mil is left is enough to work with in the joint space.
Yeah, I mean, it all depends. It's the kind of thing I like to look at and see and kind of look at the whole picture, the whole patient, but not just, you know, if it's 0.5 mLs. So not mLs, millimeters. So yeah, definitely something. And the other thing we do a lot of, because we see patients from all over the world. We've seen patients from every continent. And so people will set up telemeds or Zoom calls. They send their images ahead of time, either on a CD or a flash drive or whatever, or email. And then I can look at the images and then I can talk with the patients. And a lot of times if we do that, the patients fly in, they have the procedure done, they fly out the next day and they do the physical therapy, whether it's in India or China or Africa, wherever they're from.
Someone asked, or said that their doctor thinks they have a meniscus tear based on their symptoms and description of how they injured it. But the MRI is clean. Have you ever heard of this, or would you typically be only able to proceed if you have imaging that clearly shows the injury?
So MRI is only about 93%. So MRIs do miss some tears. They're very good MRIs, but they don't pick up 100% of tears. So, basically if it looks like a duck and it sounds like a duck, it might be a duck. It might just be inflammation. It could be some degenerative changes on the bottom part of the meniscus. But if you have symptoms and they've been present and you've done everything conservatively, then, we might want to look at either PRP or stem cells to treat the joint.
Someone else asked, is this procedure being done in other areas of the United States?
Yes, it is. I mean, it's being done at Mayo Clinic, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, Kerlan Jobe, Stedman, all the major orthopedic centers in the country. I have a lot of colleagues in Colorado, Florida, Texas, New England, who do the procedure. So yeah, it's being done. It's been done about 20 years in the United States. In Germany, even longer. And Peyton Manning and Tiger Woods had it done 25 years ago, so maybe 30 years ago in Germany.
Someone asked, do you find that people need to repeat the procedure, and if so, over kind of what time period?
Every once in a while, I'll have patients come back at, 8, 9, 10, 11 years and say, hey, you know what? It's been great. I don't want surgery. Can we repeat it? And, we look at things and see and repeat it. And patients tend to do fairly well with that. Sometimes I'll have people come back sometimes maybe at 3, 4, 5 years and say, you know what? My shoulder, or my knee, or whatever, it's been great, but kind of flared up. I walked 36 holes, in Ireland playing golf and got a little sore and now it's still sore. Should we repeat the stem cells? I said, no, let's just do a PRP booster. And 95% of those patients do fine with the booster. It takes 15 minutes and it's not a big deal.
Someone said if it's not working after 6 months, can you put a little bit more in?
Sometimes we'll do a PRP booster at 3 to 6 months if we need to. Sometimes we'll put gel if it's a knee joint or if it's got a badly arthritic hip or shoulder joint. Sometimes we put hyaluronic acid in, which is basically like putting Pennzoil 10W30 weight into the joint. So, I mean, there are options. There are ways to kind of boost up the stem cells a little bit. And I have had a few people who, I had some guy come in, a couple of weeks ago, a guy left me a note on my desk to say, yeah, he said he's 72, he's an avid hiker, couldn't really hike because he had such bad knee pain. He said, doc, at 5 months, 6 months, I told everybody it didn't work. He goes, it's now been a year and a half. He said, at about a year, my knees have just been the best they've been in 15, 20 years. He goes, I'm hiking, all the guys I hike with are in their 20s and I can keep up with them. I can hike all day long and have no issues whatsoever. So sometimes it can take a little bit longer. I've had a few people who've said that.
Someone asked, if this is so successful and helpful, why don't MDs typically refer their patients to this procedure?
I have a lot of MDs that do refer patients here. I've had a lot of MDs that we've done the procedure on, including orthopedic surgeons. I do get a lot of referrals, but there's a lot of people out there who, they're not looking at new kind of cutting edge technologies. And I mean, there are a lot of surgeons who, it's kind of like the old saying, if all you have is a hammer, everything looks like a nail, and they all got to have total joints. But I mean, I have so many patients, I mean, that are just so thrilled with their results. Granted, I'm not going to say, I'd love to tell everybody it's 100% slam dunk guarantee, but it's not. I mean, there is a chance, although a small chance, 9 to 15%, that at worst case scenario, you might say, doggone it, it just didn't get that much better. But nobody gets worse with stem cells.
Someone asked, what is the rehab for post-procedure?
It is giving those cells the external environmental stimuli that they need so that they know who to grow up to become. And it's, basically range of motion, strength, holding people back a little bit. We don't want to damage those cells. But oftentimes, patients have been dealing with this for years, and they've got all sorts of atrophy in the surrounding musculature. They've changed their gait, they've changed the way they bend and lift and twist, and so you have to kind of re-educate, those muscles and get them back and get the normal function around the joints.
Someone said they had a mild tear to their meniscus around 15 years ago. Sometimes they notice it, sometimes they don't. Can this be repaired? Because they're a runner, they don't run much anymore.
Yeah, I mean, we treat those all the time. I mean, it probably would necessitate, getting an MRI that we within a year, so we know what's going on there. But that's certainly, something that can be done and fairly easy to treat.
Someone asked why you don't treat spinal issues.
I don't treat spine for two reasons. Number one, I'm too busy with joints. And number two, in order to do spine, you have to have a live x-ray. It's called a C-arm. And they're big machines. You need a whole room that's dedicated to that. And it's got to be a lead-lined room. So, and I do not have that in the office. My son, who's going to be joining me in a year and a half, who's presently chief resident at University of Indiana, is doing some spine. We may in the future, but right now we just don't have the capacity for that.
Someone asked what's the difference in long-term results between fat and bone marrow stem cells.
So you want to do both because the gold standard, what we do at Mayo Clinic, Cleveland Clinic, Hopkins, all the major research studies, is bone marrow and adipose and PRP. Sometimes there are some places out there that just do fat or that just do burnt bone marrow. I have no idea why, because the results are so much better if you do both. The other thing about doing fat with it is it provides this collagen matrix that helps those cells adhere to the surfaces.
Someone said for a 36-year-old who's had arthritis in their ankle since 16, how do you know if they're a good candidate? How long will the results last if the treatment is successful?
Actually, I have quite a few patients that we've done that. There are a lot of times people who've fallen off of roofs, people who had bad injuries from a car accident or played, high school, college football. You want to jump on those and do them as soon as possible because it's a weight-bearing joint. They're just going to get worse with time. And at 36, there's no way in hell you're going to be a candidate for a fusion or a total joint replacement. So those, and I bet I've done some that look really, really, really bad, and I can't think of a single patient of an ankle that has gone on to have a subsequent ankle fusion or a replacement. Yeah, because I know I don't think we've seen a single one that has had to go on afterwards and do something. So I would say that's something you want to jump on and jump on quick.
Someone asked, are there standards for this procedure yet, like best practices, stem cell counts per injection divided by the space filled, etc., or is it more of like a gut feeling?
Well, we don't count the stem cells, each time. My nurses would go crazy if they had to count, billions. But they do count them at M-Site in Florida, which is where all our surgical kits come from. And so we have a general idea based on age and height of patients as to what we're going to see as far as stem cell numbers. But no, we don't count them. We do know that we're getting billions and we're getting, significant amounts of platelets, and that the counts that we get from M-Site are far superior to other companies. I always have companies coming and buying me lunch and dinner, say, "Oh, we want you to use our system," and blah blah blah. And the numbers don't hold a candle to M-Site.
Someone asked what we know about amplified wellness.
I guess I don't know what amplified wellness
It's
means.
just like they're a regenerative tissue transplant company. That's all I'm really saying.
Well, it sounds like they're getting the tissues from elsewhere, so I'd be really wary about looking to see where are these tissues coming from. Are they being cultured? Because you're not allowed to culture stem cells or tissues in the United States. Um, if stem cells are out of the body for more than 8 hours, that's against all the FDA rules. So what they do elsewhere is they subject your stem cells to enzymatic degradation. It's called stromal vascular fraction. under hoods, and they have all these enzymes that they're trying to increase the yield and the numbers of the stem cells. The problem with that is there's a potential that you can damage the ends of the chromosomes, which are called telomeres, and then there's a potential for malignancy, which is not the case. That's when we do a procedure, those stem cells aren't out of your body for more than 15 minutes.
Someone asked if they do both knees at the same time, and how soon can they climb stairs and like walk out of the clinic and stuff?
Oh, patients walk out of the clinic, within half an hour or so of the procedure being done. Stairs, it varies. Some people, I have some people who come in and they're from out of the country and they go and walk around Green Lake afterwards. But you're sore, you're achy. I tell people, take it easy. Whatever feels okay is fine. Some people may just, walk around their house for the first, day or two or around the block. But usually walking is not a big issue. I tell people, take your time with stairs, use the handrail. I wouldn't just go do stairs for the sake of doing stairs right at first.
Someone else said, do you know if there's anyone locally that will treat spine issues?
There's nobody really good in Seattle for that. We do have a clinic that we refer to in Portland, although I think Raul retired.
I do believe you retired, yeah.
Although he has some partners who are doing spine, and then we have somebody else who's in Vegas who does a good, and that's something you could call the clinic. We can get that information for you.
Someone asked if they'll be able to fly within a week of treatment.
Yeah, flying's not an issue. We have a lot of people who come down from Canada and they fly Lake Union Air, and because it's right behind our office, and they fly in, they walk up to our office, they have it done, they walk down, they fly out the same day. But we have people that come stay at there's a hotel right next to our office, and then they fly out the next morning on a commercial jet somewhere. So that's not an issue. I just tell people, don't sit for the whole flight for 18 hours back to Australia. Get up every 2 hours and walk up and down. We don't want people to get blood clots by sitting for a long period of time.
Someone asked, other than the chance of gout, what are common possible negative side effects, sorry.
Just some inflammation. You can get what's called a PRP flare, and for a few days you can get inflammation and pain in the knees, and may necessitate putting some lidoderm patches on, or having you take Tylenol or maybe some hydrocodone for a few days.
Someone asked if it's only you at your clinic, or do you have other doctors?
Presently, it's only me. My son will be joining me in about a year and a half.
Another person asked, do you keep their samples in a database so that if they came in later, you know what their levels were previously? I assume for like amount of stem cells.
Keep their sample, like freezing.
That's
we don't. We're not a cryo facility, so we can't freeze stem cells. I know some people do it, like when they have a newborn, they freeze their stem cells and stuff like that. I haven't done any where we basically took that out, of somebody who had frozen their own stem cells. I had somebody ask me the other day, actually. One of the surgeons at the meeting I was talking at said, well, we had stem cells frozen for our daughter when she was born. She's now 24. She unfortunately had two really botched surgeries on her knee, and the surgeon asked if I would see her. She's going to fly up, and he asked, could we use those frozen cells? I said, it's so easy to get fresh cells in high numbers that I think we're best to just do that.
He actually did clarify. He said he's actually just wondering about numbers of stem cells per unit.
So no, we don't count them here. We don't have the big machine that counts stem cells like they do in Florida. So yeah, we don't. We have CCs, that we know how many CCs we're putting into a joint, but we don't have numbers per se.
Someone asked how soon they can get treatment, like in terms of getting into a consult and the procedure, and then that kind of stuff.
I think Chelsea will schedule you for 7:15.
Yeah,
just
tomorrow morning. Come on.
No, we're usually we can get people in for a consult within a week or two. And the same thing for procedures. We can usually get people. We're not like UW. We're not like Franciscan or what's the other, Kaiser. it's not corporate medicine. I'm not owned by anybody. I practice medicine the way I was taught to practice medicine 35 years ago by Keith Peterson, that if people need to get in, we get them in. I don't care if we do it over lunch or we come in early, we stay late, and we get people in, because nothing drives me crazier than somebody telling me, yeah, I'm trying to get in to see the doctor at UW, and they're telling me it's 6 months, or they just didn't return my phone calls, or I sat on hold for an hour and a half and I still can't get the results of my studies. So we kind of practice medicine the old fashioned way, and I really like it that way.
Someone asked, PRP for early osteoarthritis of the hip.
Yeah, I mean, possibly, it all depends. I mean, certainly the quicker you jump on things, if you catch patients with mild osteoarthritis, you want to jump on them as soon as you can, because they do so well. But it's a weight bearing joint, it's going to get worse with time. So I usually tell people, probably better off, if you actually truly have osteoarthritis, to do stem cells and PRP.
Someone asked, is it being done in this area outside of our clinic?
Yeah, I mean, there are other people who do it. Unfortunately, you gotta really look and see, who's doing it, what their degree is, where they're getting the stem cells from, how many have they done. So you want to look at, I think, we get from our surgical supply company the data and the numbers. I think we've done more than anybody in the Western United States. So, we certainly have a lot of experience with it.
Someone asked about what the cost would be for knees.
Knees are running, they're not running. They're basically 8,000 for a single joint and 11 and
11.5.
change for two joints.
Yeah. Don't have anything else right now. If anyone has any other questions, they can pop it in the Q&A.
And then we'll send like a PDF of our clinic, all the information that we usually send out to patients. So that'll just come on an email. And yeah, if people have further questions, shoot us an email. If it's a consult that you need, just all you need to do is call. Our front desk is great at jumping on those. And if they can't answer because they're too busy up front, they get back very quickly to patients. And then we can see, if you are a candidate. If you're not a candidate, I'm going to tell you, because I don't want to do patients who I don't think are going to do well. So, well, thank everybody. Thank you all for attending. And yeah, if I can be of more assistance, just let me know.